In the practice of obstetrics, there are many clinical skills that must be mastered. Of these, manual rotation of the fetal head and operative vaginal delivery are two procedures that can help the obstetrician avoid cesarean delivery for their laboring patients. In order to be successful with these two procedures, the obstetrician must become proficient in identifying fetal head position when examining the laboring cervix of vertex-presenting infants. Hello, my name is Christopher Morosky, and welcome to the University of Connecticut. In this video, my colleagues and myself will introduce you to the important aspects of checking for fetal head position. The goals of this video are as follows. Understand the bony anatomy of the fetal head. Review the various positions of the fetal head while in labor. Suggest simple and detailed methods for identifying fetal head position via the digital labor cervical exam. Discuss how knowledge of fetal lie via Leopold's maneuvers can assist with assessment of fetal head position. Introduce a novel method for using trans-abdominal ultrasound to improve the accuracy of identifying fetal head position. We hope that you find this video enjoyable and educational, and that you refer to it often as you begin to master these important clinical skills. Okay, now let's get started.
Hello, my name is Pooja Glopati. I'm one of the University of Connecticut medical students. In this segment, I will review some of the bony anatomy of the fetal head. Relative to labor, there are three major components of the fetal head that the obstetrician must become proficient at identifying. These are the individual bones, the suture lines, and the fontanelles. Looking more closely at the top of the fetal head, the following bones can be appreciated. There are two frontal bones in front just above the brow. There are two parietal bones on the sides of the fetal head, and there is a singular occipital bone on the back of the fetal head. Since these soft flat bones are not yet fused, where they approximate each other creates specific fontanelles and suture lines. The fontanelles are soft small openings in the bony fetal head. The posterior fontanelle is a triangular-shaped, soft opening where the two parietal bones and a singular occipital bone come together on the back of the fetal head. The anterior fontanelle is a diamond-shaped opening where the two parietal bones and the two frontal bones come together on the front of the fetal head. Suture lines are the areas of overlap between two abutting bones and can be thought of as small fault lines between two tectonic plates. On the very top of the fetal head between the two parietal bones is the sagittal suture line. On the back of the fetal head between the parietal bones and the occipital bones are the lambdoid suture lines, shaped similar to the Greek letter lambda. Because there are four bones that come together to create the anterior fontanelle, there are two suture lines in this location. These are the coronal suture lines between the frontal and parietal bones and the small frontal suture line between the two frontal bones. Alright, now that's a comprehensive review of the top of a baby's head. Let's hear a little bit more about fetal head position from Dr. Morosky.
It is important to keep in mind that when we are talking about position of the fetal head, we are talking about the location of the occiput, or the back of the fetal head, in relationship to the right or left side of the maternal pelvis. When the occiput points directly down and the infant is looking straight up, this is referred to as occiput posterior. When the occiput points directly up and the infant is looking straight down, this is referred to as occiput anterior. Aside from the direct positions, the infant usually favors either the right or left side of the maternal pelvis. This often has to do with how the infant is lying within the uterus. More on this later. Most babies will enter the pelvis in some type of posterior positions and rotate to the anterior in labor. For right-lying babies, the head can be thought of as rotating from occiput posterior to right occiput posterior, and then to right occiput transverse, where the head is now completely in the transverse plane, and the occiput is to the maternal right. Further rotation brings the head to right occiput anterior, and finally to occiput anterior. For left-lying babies, the head rotates from occiput posterior to left occiput posterior, and then left occiput transverse. Then on to left occiput anterior, and finally occiput anterior. One last important thing here, and this is somewhat confusing. When the infant is in the posterior positions, ROP, OP, and LOP, it is the anterior fontanelle that is most easily palpable. When the infant is in the anterior positions, ROA, OA, and LOA, it is the posterior fontanelle that is most easily palpated. When infants are in the true transverse position, both the anterior and posterior fontanelles can be palpated in the margins of the pelvis. In the next segment, we will head over to the classroom and learn a little bit more about digital assessment of fetal head position when performing the labor cervical exam. Digital assessment of fetal head position is an important aspect of the labor cervical exam. It is quite difficult to palpate enough of the fetal head at or under 5 centimeters dilated, and this exam must be performed once the membranes are ruptured. However, by 5 or 6 centimeters dilation, and certainly by the time the cervix is completely dilated, digital assessment of fetal head position should be performed. There are two approaches to the digital assessment of fetal head position. One is to palpate the fontanelles based on shape, the other is to palpate for the number of suture lines. In the first approach, the examiner palpates for the shape of the fontanelle. In the ideal situation, the posterior fontanelle is palpable as a large, smooth triangle due to the presence of the single smooth occipital bone. Conversely, since 4 small bones come together to make the anterior fontanelle, this makes the anterior fontanelle feel like a very small diamond. Unfortunately, with any amount of molding or extension of the fetal head, determining the shapes of the fontanelles can be difficult, as both can feel like very large triangles. A more reliable approach is to palpate for the number of suture lines. In the posterior fontanelle, only the 2 widely spaced lambdoid suture lines can be palpated. By running the finger back and forth between the 2 widely spaced lambdoid suture lines, no other small suture line can be felt because here again is the smooth single occipital bone posteriorly. In the anterior fontanelle, the 2 coronal suture lines can also be palpated across from each other, and in many cases this feels like a large triangle. However, the difference here is that with great care to palpate between the 2 coronal suture lines, the very small 3rd frontal suture line can also be palpated here as well. The frontal suture line is very small and fine, and great care must be taken to attempt to palpate for it. Once the proper fontanelle is identified, then assessment needs to be made to determine if the fontanelle is on one side or the other. For the anterior fontanelle of the occiput posterior facing babies, the fontanelle will be palpable on the side of the maternal pelvis that is opposite to the occiput. For example, if the anterior fontanelle was palpable in the 10 o'clock position, this would be on the side of the maternal right. This represents an infant that is looking up and has the occiput down and to the left. This position therefore would be left occiput posterior. For an infant in the right occiput posterior position, the anterior fontanelle will be palpable at 2 o'clock on the left side of the maternal pelvis. Confusing, right? You really have to work hard to think about this when doing these exams until this becomes second nature. Fortunately, for the occiput anterior positions where the posterior fontanelle is palpated, the posterior fontanelle is located on the same side of the maternal pelvis as the fetal occiput. For infants in the right occiput anterior position, the posterior fontanelle is palpable at 10 o'clock on the right side of the maternal pelvis. For infants in the left occiput anterior position, the posterior fontanelle is palpable at 2 o'clock on the left side of the maternal pelvis. It is important to mention something about the transverse positions, although they are much less common because the fetal head quickly rotates past this position. But for patients where the fetal head is stuck in the transverse position, Both fontanelles can be palpated by reaching back and around at 3 o'clock and 9 o'clock in the transverse plane of the pelvis. We recommend that you reference this section of the video often, and even better, get your hands on a simulation baby and begin to practice palpation of the fontanelles and suture lines in relation to the position of the fetal occiput within the maternal pelvis. It's gonna take practice. And now on to other things that will help with your assessment of fetal head position.
As you heard earlier, determining which side the infant is facing is one of the more difficult parts of assessing fetal head position. Sidedness comes from which side of the maternal body that the infant is lying on, also known as fetal lie. And as it turns out, infants lying on the maternal left will present left positions, LOP, LOT, and LOA. And infants lying on the maternal right will present right positions, ROP, ROT, and ROA. There are many parts to Leopold's maneuvers, but one of the most important parts is determining the infant's lie by examining the uterus through deep palpation of the abdomen, which can be done as follows. After confirming the cephalic presentation of the infant with the firm head palpable at the symphysis pubis and the soft breech palpable in the upper abdomen, the examiner then palpates on either side of the uterus. The side where the infant is lying will be firm as it is filled with the body and the back of the infant. The side without the infant will be soft and volatile, as it is mostly filled with amniotic fluid and perhaps placenta. Leopold's maneuvers are often performed at the time of admission in labor or at the beginning of an induction. Additionally, performing Leopold's maneuvers following a digital exam of the cervix can help with the assessment of fetal head position.
Another option that is gaining popularity is the use of transabdominal ultrasound to assess the fetal head position. Hello, my name is Courtney Townsell, and I'm one of the University of Connecticut Maternal Fetal Medicine Fellows. Similar to Leopold's maneuvers, ultrasound can help identify fetal lie and determine if the occiput is going to rotate to the maternal right or left. Ultrasound can also identify the presence or absence of the fetal eyeball. This can assist in identifying occiput anterior versus occiput posterior positions. Let's take a look. The first step is to confirm the cephalic presentation of the fetus. This is done by scanning over the maternal pubic bone and identifying the fetal skull as a large white circle. Hold the transabdominal probe transversely to obtain this view. While in this position, scanning up and down will allow the examiner to identify the presence or absence of the fetal eye. The eye appears as a small black circle within the white circle. The presence of the eye would suggest an occiput transverse to occiput posterior position. Finally, holding the ultrasound probe longitudinally, the examiner moves to the side of the uterus to identify the fetal cervical spine, continuing from the head and into the thoracic spine. The spine appears as several closely spaced white bones. The cervical and thoracic spine can usually be seen in the lower part of the uterus. The side of the uterus containing the spine is the side of the fetal lie. This will also be the same side that the occiput of the fetal head will be positioned. Combining your ultrasound findings and your physical exam findings should increase the accuracy of your assessment of fetal head position.
Well, that about does it. Thank you for taking the time to watch this video on assessment of fetal head position. We hope that you find this video helpful as you begin to learn, practice, and master this important obstetrical exam skill. Your patients will certainly benefit from you incorporating assessment of fetal head position into the routine part of your laboring cervical exam.